5, 4, 3, 2, 1. Let's go. Diary of a Kidney Warrior podcast in partnership with Kidney Care UK, sharing faith, knowledge, hope, and love.
Hi, and welcome to Diary of a Kidney Warrior podcast. My name is Dee Moore, and I am a kidney warrior. This podcast is dedicated to encourage, educate, and inspire as we explore all aspects of kidney disease, related chronic illnesses, and health. If you have any questions or ideas for topics you would like me to cover, please get in contact with me on social media using the handle Diary of a Kidney Warrior. In today's episode, we're exploring how primary care can better support people living with chronic kidney disease. This is the first in a two-part series featuring Dr. Kristin Veighey, who joins me to explain what happens beyond the GP's office. We'll be talking about the wider team involved in kidney care, common misconceptions in primary care, and how you can advocate for yourself to get the support you need. Stay tuned for an empowering conversation. Hi, and welcome to Diary of a Kidney Warrior podcast. How are you doing today, Dr. Kristin?
I'm good, thank you. How are you?
I'm good. I'm really good. I'm looking forward to our interview today. Listeners, we are looking at the subject of Beyond the GP, making primary care work for kidney health. There's a lot to unpack in there. We go to our GP. There's a lot of other health professionals that work with GPs. And sometimes information can be lost or things that we don't understand. And so today is really a follow-on from episode 84, which was chronic kidney disease in primary care. What do I need to know? So today is further information, more about primary care. We want to empower kidney warriors, including myself, to know how to manage their kidney disease, know what to expect, and know what services are available to them and from who. So that is what today's episode is about. So I like to start with definitions because I think when there's a topic that people don't necessarily know what the title is or what the words mean, because sometimes we hear these words used a lot, but we don't necessarily know what they specifically mean. So I like to start with definitions and then move further on in terms of the topic. So my first question is, what is primary care?
So I think that's a really good question. And I think sometimes systems change and we're not very good at explaining to people what these new things mean. And I think it became used almost as an interchangeable term for general practice. But actually, general practitioners are GPs and they're doctors. And primary care is a team sport, really. It's doctors, but also nurses, not just practice nurses that we'd think of as, people who do baby immunizations and wound checks and things like that, and give injections. But also we have specialist nurses that work, for example, looking after patients with asthma that work in primary care. We have acute care nurses, both in our practice and people who go out to people who are sick at home to assess them. We've got frailty nurses. We've got pharmacists who are fantastic at doing medication reviews and making sure people are on the right medicines, both, I think, for kidney health, making sure they're on all the new things that they could be eligible for, but also making sure they're not on medicines that are going to do them harm, because we all know there's a list of medicines that can be harmful to patients with kidney problems. So pharmacists help with that. In a lot of practices, they manage blood pressure. And then there's some sort of other additional roles within primary care networks. So GPs surgeries are sort of organised into a group called a primary care network. And those networks, ours has got 8, soon to be 9, for example, practices. And that covers about 47,000 patients, so just as an example. And then in that group, we can have the services of, for example, a physiotherapist. We've got a social prescriber or social prescribing link worker. They're brilliant people for knowing what is in the community that can support patients. So support groups, charities, advocates, great at knowing what benefits, I know that's probably quite topical at the moment, but benefits and support people are able to access and how. So they're good at that sort of stuff. And then we've got health coaches. So health coaches can help with lifestyle measures. And so one of the things I advocate a lot for is people with earlier chronic kidney disease, where sometimes I think the system doesn't necessarily know what to do. It's not at the point where we're going to do drugs or send people off to the hospital. Actually, those lifestyle things are really, really important. And health coaches can support people to set goals, and they do through behavior change techniques. They empower people to take control of their own health and work towards specified goals, whether that's weight or mental health or whatever it is. They work holistically with people. So, but I'm not always sure that, the public and even secondary care colleagues are aware that we've got all these people. Our practice has mental health nurses as well. So they're another great support because they're actual people. They're not a online talking service or something like that. They're a real person that can be seen in the practice in person where people live. So that's a great resource as well. And again, another thing I advocate a lot for is we know that the rates of anxiety and low mood are very high in people with chronic diseases, including chronic kidney disease. And actually, the support is not universally available to try and help people manage and navigate that. And I think a lot of people think it's almost a normal thing that they should just get on with, when actually there are people that can help and support on that journey.
So really, there's a whole wealth of professionals there that are there to help people as a first step in terms of their care. So I think generally when you think of primary care, or let me just speak for myself, you just think of the GP. You don't actually think of all those other different professionals that you've named, especially the other ones that you named. Like, I don't know, again, I can only speak for myself, but when I think of a pharmacist, I think of someone that dispenses my medication. I don't think necessarily that they're making decisions in terms of what medication that I have and whether it's best for me as a patient. I'm thinking that decision is made by the doctor or the consultant only. So it's very interesting actually that they do play a part in that process, and they were actually part of that process as opposed to someone who has the sole purpose of dispensing medication. I know they do blood pressure and all the rest of it, and they're doing more, but I didn't realize actually they are part of primary care. So I find that really interesting.
And I think the fact that we've not communicated that well, it causes a lot of anxiety for patients, because I think before I came into primary care, I'd have been the same. I'd have seen the pharmacist as someone behind a counter and a chemist who's making up drugs. And I know in the hospital, they are amazing at making sure you don't do something silly with prescribing. But I think in primary care, we don't think of it in the same way. But actually now they can be responsible for prescribing blood pressure medication. And actually, we know that some of the blood pressure medicines that we use for kidney health, so things like ramipril and candesartan and those drugs, need multiple appointments to get to the maximum dose, and they need blood tests to check kidney health in between. And actually, if you're waiting for your GP to have capacity to do that, it's just going to take forever. We know in our practice it can take 1.5 years, which is ridiculous, just because we know how many appointments. But actually, if you can get other people in the team involved, that can happen much more quickly under the oversight of the GP. But actually, we can lay out guidelines that people can follow that really help them to be able to sort of drive care forward in a quicker way, a more time efficient way for patients as well.
I think it's really important that patients do know that, because I think in some ways it kind of comes across as, well, why am I not seeing my doctor? Isn't that my doctor's job to do?
Yeah.
But actually, now there's a whole team, a multidisciplinary team of people that are actually ensuring that your care is covered and in a timely way. We know that NHS waits are very long at times, depending on which one it is, which trust it is. But ultimately, if you've got a whole team of people who are specialists in their area, then you can get seen and get treated quicker.
Yeah, and I think in our practice, we talk about continuity in teams, which, having worked as a nephrologist and had that lovely joy of pretty much seeing the patient every single time in clinic, I think that doesn't really work in modern GP, because people tend to work long days, but they maybe work 2 or 3 long days and do other things. So actually, you can't easily see in the same way in the hospital. If you're in the ward for a week, you won't necessarily see the same junior doctors every day, or resident doctors as they're now called. So we tend to think of continuity as a team thing as well. So in the practice I work in, my sort of principal GP supervisor has a team of people that work with her, and we share the patients. So you will always see someone within that team. It just might not be the same person. And I get, as a patient, I think we'd all agree that's not perfect, but it is at least an attempt to maintain some degree of continuity and oversight rather than it just being completely random and haphazard.
I really want to look at navigating the primary care system. So my next question is, how do you navigate the primary care system?
So I think that's another good question. And I think even as people who work in it and work in the healthcare system, it can sometimes be quite difficult. And I think every practice works in a different way. So that's quite confusing as well. Some practices, there's that sort of big mad scramble at 8 o'clock, people queued outside the door trying to phone up to get appointments. Other places have greater sort of online access where you can put in e-consultations. Our practice has got access to an AI type e-consult system that runs 8 to 8, Monday to Saturday. But I think we're quite unique in that way. So I think trying to get in the door can sometimes be quite difficult. And so I think it's being very clear in those things, what you need and what you want. And I think patients who are kidney patients and are used to secondary care have probably a greater sense of what they need and want in some cases. That can be quite intimidating sometimes to GPs because you'll know more than they will. And if you sort of ask them, I'm sure they'll tell you that because they're generally quite upfront, certainly about the fact that they don't know so much about the advanced stages of kidney disease. But I think sometimes you have to just say, this is what I think is going on, this is what I need, and I need someone to help me with that. And they will hopefully be able to help. I know sometimes timeliness can be a challenge as well. I think in secondary care, when you're in a specialist service and you need help, usually you get that help relatively promptly, I hope. Whereas I think in primary care, the systems can take a little bit longer to wend their way through. And sometimes it can be difficult to, our GP practice, often I find popping in and having a chat to someone is the quickest way to get something done. That's not ideal, but it sort of, it makes things work. And I always find a face-to-face approach is useful for building those bridges. But I think we'd all agree that we'd like it to be better. There's not enough GPs, despite the fact that lots of my colleagues can't get jobs. We've got a slightly strange system at the moment where there aren't enough GPs, there aren't enough jobs for the GPs that are being trained, which is bonkers when we need more capacity for people to be seen in a more timely fashion. So I'm not sure that sort of provides a solution. I guess we all empathise with the challenge, and I'm certainly not opposed to people being able to tell us what they think they need, because that helps us to prioritise as well.
You covered quite a lot there, but actually something that I think just need to cover, because we started with the definition of what primary care is, but you mentioned about secondary care. So just very quickly, what is secondary care?
So that's a good point as well. So secondary care is typically hospital services. There is also another layer, tertiary care, which is sort of super specialist hospital services, and transplant and dialysis services would fall into that. So you'll probably know some hospitals have kidney care, like Southampton, for example, where I work, we have a bit of dialysis on the wards, but really we don't have the full remit of kidney services. The renal unit in Portsmouth is where all the tertiary transplant stuff happens. So we're sort of split now into primary care, also community care, which obviously the government is really hoping is going to grow. Then we've got secondary care, which is hospitals, and then within the hospitals, these super specialised bits that are often sort of funded in a special way because of how specialist they are. And I think we probably could be doing a lot more to work better together, because I think having worked in the hospital as a consultant and then now working in general practice, there's lots of stuff that the me in either of those settings didn't know about the other setting, and lots of things that I understand now that I think are quite helpful. And I guess relevant to this, I think we know that as people transition through their kidney journey and they get into the later stages of chronic kidney disease, sort of stage 4, stage 5, they start to sort of pull away from primary care because obviously GPs really don't know the specialist ins and outs in the way that the specialists will. But actually then they maybe lose access, or it's not as obvious to them, these other things that might be helpful that as a nephrologist I didn't know anything about. Some of them maybe things like, women's health, mental health, things where there are services in the community that can support people with those things. So I think we need to work better together, really, to make sure people don't fall through the gaps.
So following on from that then, how do you know who should cover what? Because like you said, especially for myself who is in end-stage renal failure, it's like I don't see my GP as often as I do see my consultant and my renal team. So I kind of feel quite disconnected from primary care now because of the stage of kidney disease that I've reached. But who really should cover what? Because sometimes as a kidney patient, you can get in this tennis ball match of you ask your renal team something, oh, go to your GP or this, that and the other. And I'm like, and then you think, well, they don't understand about this in connection with my kidney disease. So they're just going to be asking you in the end. So why can't I just ask you? And sometimes there can be kind of this tennis ball match between which team, or is it primary care, is it secondary care's responsibility to cover this? So my next question is then, who should cover what?
So I think it's hard to be completely specific about it because I think nephrologists are actually quite good holistic specialists. So that's not to be disrespectful to other specialists within the hospital, but I think we do, because kidney disease can be impacted on and impacts on so many aspects of people's lives, we get a bit more knowledgeable about things that would probably actually be GP things. I think things like infections, chest infections, tonsillitis infections, those sorts of things can be managed quite well in GP. And I think what's changed for me over time is that GPs should have kidney patients on their system. There are these things called codes, and codes are basically labels, and they're what comes up on the NHS app in that list of problem list or whatever it's labelled as. And so if chronic kidney disease stage, whatever it happens to be, appears on your NHS app, that will be in your GP system. And so if the GP tries to prescribe a medication, it will flag, actually don't do that because this patient has got kidney problems or is on this medication that would interact with it. So things I think are a lot safer now than they might have been in the past for that reason. But it means it's really important that those codes, those diagnostic labels, those sort of kidney disease labels are on people's records. And that's something that causes a lot of anxiety at the moment because I think the GPs and the primary care teams are thinking, well, I really want that on there because then it will tell me if I'm going to do something daft and I'll make sure I don't give them too much of this medicine. But obviously, sometimes that isn't relayed through to the patient at the time it appears on their record. And so we know people are finding it and going, oh my gosh, no one told me about that. And actually the GP's thinking, oh, I've got to tell them and I've got to talk to them about it, but I can't do that right this second because we all know cold calling people while they're in Sainsbury's isn't great either. So there's that tension of wanting to do the safe thing and not. But I guess in relation to the question, I think prescribing of things should be safer than it was before. I think skin conditions and that sort of thing, much better dealt with in GP in a way. GPs have got access to rapid pathways for anything that feels like it might be nasty. So we've got these 2-week wait cancer pathways. So anything that you're worried might be anything at all, losing weight, nasty tummy pains, changes in bowel habits, any bleeding from anywhere, funny moles, all of that stuff, your GP can get access to much quicker specialist opinions because you go straight into this system that pushes people through. So I think anything like that, definitely. I think mental health, renal units are starting to catch up with having psychology support and counsellors, but not everywhere has. Our region has got mental health practitioners with specialisms in chronic health problems. So not just any old person, but people who actually specialise in supporting people with chronic diseases. So that can be quite helpful. And I always think the one that used to always make me really anxious was women's health, because as a nephrologist, I really wasn't sure what contraceptive options were there, what was safe, what was not safe, what could I give someone, what could I not, what advice should I be giving them. Same with HRT. Was the tiredness a kidney disease, or was it menopause, or was it both? And what could I give them, and what preparation? And I think I feel a lot more comfortable with that now. That may be because I've got, both expertise and I can pull that together. But I feel like I'm spending a lot more time in the kidney clinics that I do, talking to people about some of these other things that I now feel I can actually help them with, that before I just felt it a bit of a loss. Yeah. Vaccinations and things like that, obviously GPs can do as well. So obviously if you're registered again with that code thing on your NHS app, you should be eligible for vaccinations and through your GP. So that's another safety aspect of making sure that's on record, because then that will automatically make sure you get things like the flu jab and so on offered when that comes around.
So you mentioned about the code, but how do you know where the code is? If you have the code, where do you look for that?
So if you're looking in your NHS app on the summary page, there's usually a list of sort of conditions that you've had, and chronic kidney disease should appear on there. And one of the things we know is that the NHS used to give GPs financial payments to keep a list of people with chronic kidney disease. And they've taken that out now. They've pretty much taken out anything really to do with kidneys from that scheme, which is bonkers given how we know kidneys have become, even for the WHO, a global health priority. So the only thing that GPs get funded to do for people with kidney disease at the moment is offer them a statin, and they have to do that every year. And so it can be a bit annoying if it's been decided that's not appropriate, because the GP has to ask you every year, because they can't assume that your decision last year will be your decision this year. And that's all done on these codes. But we know that the codes are not always up to date. So one of the things I would say is, check if you've got kidney disease, make sure it's there, but make sure it's right as well. We know in our practice, we did some work and lots of the dialysis patients didn't have a chronic kidney disease code. I think because probably whenever they end up with dialysis, everybody thought it was obvious, but it actually needs to be documented on there to trigger all these sort of alerts within the system to make sure you get all the things you're entitled to. So really, really important. And I think for GPs, it's a chicken and an egg thing. I think sometimes you're sitting doing results, or it could be the pharmacist or the nurse, as we've said, and you spot, someone's got chronic kidney disease and that's not coded, so that diagnosis isn't there. And you want to do that immediately because you want the safety benefits of that being there. But obviously sometimes that, like I say, that information doesn't get to the patient at that time. So that's something we really need to work better at, making sure that the safety benefits are there, but also that people are aware that has gone onto their list, so they know what that means for them.
So where does the buck lie then? Because you have the situation where I've seen for myself, obviously this is anecdotally, this isn't everyone, but I see time and time again that people don't know. They're not told by their GP that they have kidney disease. The GP's known for X number of years and hasn't told them. So it's like, why are there these misconceptions around CKD in primary care? Because obviously, I mean, for me, looking back on my blood results, it was clear that my kidney function was declining. No one told me. And I look back and I think, well, how much more could I have done to potentially slow down or even reverse what was happening to my kidney? So I didn't find out until it was very advanced. I was stage 4. And I'm a firm believer in prevention is better than cure. So why are there these misconceptions in primary care in terms of the guidelines, targets, and thinking around CKD, when earlier on so much can be done?
Absolutely. And it's always struck me that, we were taught as medical students that when your creatinine, back when we didn't have EGFR, when it went up, that was your kidneys were already damaged. And yet we sort of almost wait until things have got bad before we call it a thing. And I think that's a system sort of issue. So EGFR, estimated GFR, came in as a thing in the sort of 2000s. And EGFR and thinking of stages is a relatively recent thing in thinking. And even in our guidelines that were written by nephrologists for GPs, the NICE guidelines, the last version of that is 2021. So that's a few years ago now, and nephrologists, I think, really feel those need to be updated because a lot has happened in that time. But I think one of the issues is that the guidelines and at the time, this financial payment for keeping a list was designed to capture people with chronic kidney disease stage 3, 4 and 5. So 1 and 2 weren't on anybody's sort of radar at that point. And clearly there's something very different between someone who's 80 and has had chronic kidney disease stage 3A for 20 years and is fine, and someone who is 20 and has chronic kidney disease stage 2, but their GFR is 64. And I think now that we've got things that we can do, both drugs, but also, as some patients reminded me recently, it's not all about drugs, it's about lifestyle. And actually, I think a patient that I was talking to recently said to me, well, actually, as doctors, you're all very interested in when can we tell you so we can start the drug? And I'm like, well, actually, what about the stuff I can do that empowers me to look after my health? Actually, I'm delighted if you tell me you don't need a drug because it's not that bad yet, but you could do these things to support your own health. So I think we really need to change our thinking across the board. I think we need to see the patterns like you describe. It's not about a numerical number. The old version of the guidelines said wait till it drops into stage 4 or at that time 30 before you refer to nephrology. So we used to get a lot of, just keep watching it fall and then tell us when it gets to this arbitrary cutoff. And clearly that doesn't make any sense either. And we've got so many new treatments now that actually we know if we start them in CKD stage 2 in the right patients, we will make a difference. And I think one of the things I'd say to people is that the key around getting sort of access to those medicines is understanding what your kidney function is doing, as you describe, and is it getting worse, but also how much protein or albumin is in your urine. So having your urine albumin creatinine ratio done. And what I've said to patients in the groups that we've run is go to your GP and tell them, here's my urine. I know this needs to be done every year. It's in your guidelines. Because I'm in an at-risk group, I need this to be done. And encourage and educate people to do that because they won't necessarily know. I think there's also this sort of slightly odd perception that people won't give urine to GPs. Maybe it's because in kidney clinic, I can't imagine a patient coming to kidney clinic without urine. It just doesn't really happen. So I think we just need to change that. People are very happy to bring urine when they think it's infection. So I think we need to actually explain to people why we're doing those things. We're trying to find people who are at risk. We're trying to make sure they're on the right treatment. I think we need to be coding people across the board according to the risk of, that they have of progressive kidney disease and not just based on a number. And we probably need some better guidelines around what's abnormal in different age groups. So another one of my slight bugbears in primary care is that blood pressure target is set to 140/90 for everybody until you get over 80, and then it's 150. And for us, thinking in a kidney way, I would definitely not want a 20-year-old's blood pressure to be 140. That would start raising alarm bells. And so I think individualized targets are really important. And again, the British Heart Foundation have done a lot of work around what is your blood pressure, knowing your numbers, knowing what's normal for you, having individualized targets. So not just what the computer says, but actually what's the right thing for the patient. So we can hopefully catch all of this early because, as you say, there's lots that we can do now. And it's almost a shame that it's taken us to have medications and for pharmacy companies, really industry companies, to have to push the agenda for us to do what has always been the right thing to do. But now we've got medications that are sort of almost helping drive that agenda, I think.
So there's a lot there that is out of our control as patients, but as patients, how do we get what we need?
So everybody who has either chronic kidney disease stage 3 to 5, and as I say, that's what sits in the guidelines at the moment, and probably all agree we could do better, should be having a kidney health check at least once a year. So I think this is the other thing people see annually and they revert to annually. Let's do it every year. Clearly, it's dependent on the person, the stage of kidney disease and the likelihood of it getting worse. Plus, I think what you're doing, clearly, if you've started a new medicine, I had this debate with a GP colleague recently. you might want to monitor something a bit more frequently because you want to make sure that what you've done is working. Don't want to find that out next year. So I think there's that, and that is in guidelines. So that's something that I think patients should feel empowered to ask for because they should be having that. And a kidney health check to me means a blood pressure, EGFR blood test, and a urine ACR urine test, and that should be done every year. I think if you're earlier stages than that, I think you should be sort of encouraging your GP to look further if you're younger. So for some people, it's quite obvious to me, older people, and maybe who've had blood pressure and cholesterol and diabetes and other problems for a period of time, I can think, okay, yeah, that's probably why they've got chronic kidney disease. And it's been nice and stable for quite a long time. And we can check their urine ACR and that's normal. And then maybe we just keep an eye. But I think if you're 20 or 30 and you've got an EGFR that's not normal, and I will say normal is over 90, don't need to get in a sort of a panic, but I think I would be saying to the GP, actually, do you know what, would you mind if we check that again in 3 months to check that's not a chronic change, that's a blip that has happened. I've had drops in my kidney function. I have my bloods done for another medical condition, and I've had drops in my kidney function when I've been on call, because when you're doing night shifts, you don't drink and you don't weigh and you don't eat. So those things do happen. But for me, I see too many people. I saw someone last week who's now got kidney disease stage 3, but actually a few years ago had a GFR of 70. And as a nephrologist, because they're in their 30s, the alarm bells are ringing. I'm thinking, that's not normal. It's probably nothing to worry about, but I just want to do one more blood test and make sure that's gone back to normal. And if it hasn't, at least we've picked it up. And even if we were doing annual, I think it was 2015 that their EGFR had been low. If we'd been doing annual checks, we'd have picked that up earlier than down the line when they've presented either with something else or because they've developed symptoms because things have got that bad. I think the other thing that's probably, as a professional, I've learned is some of these vague symptoms can be a herald for something. So, historically we used to tell people, until you've got stage 4, you don't get symptoms from your kidneys. That's clearly not the experience of patients. So, I think just making sure that, if you're feeling subpar, that, you get your GP to investigate that. And just, even if it's to put your mind at rest, because I think that is really important.
I know you've already touched on this area in terms of patients advocating for themselves, but I just want to give space for anything else that you feel that patients should know that's important for them to know so that they can advocate for themselves.
Yeah, I think it's important that people know what the numbers are, so know what their blood pressure and their EGFR and their urine ACR are and what they mean for them. I think there's a genuine amount of anxiety in general practice about causing unnecessary alarm to people, because I don't think I really believed that was a thing when I was in secondary care. But obviously by the time you get into a specialist clinic, people have had some information, so they know they're going to see a specialist because there's a problem. Whereas in primary care, you might be introducing something for the first time. And of course, it's not our role or our job to decide what information people should or should not be given about their health. We have had people coming to the surgery crying because we've tried to tell them they've got chronic kidney disease, and the term sounds really awful. And actually, it can mean very different things to different people. It can be something that they've got that is there that means we're going to be really careful about what medicines we give them. We're going to try and tell them not to take lots of ibuprofen. We're going to make sure they're drinking enough, especially when it's warm. We're going to do all these things, but we're probably not going to put them on lots of new drugs and things like that. And there's other people we're going to be watching really, really closely because they're at higher risk. So I think knowing what the things mean for you is really important so that you know not to worry. And one of the things that struck me recently was I've got a patient who does some work with us in group education sessions. And she said that when she found out she had stage 3 kidney disease, she thought that was like cancer stage 3. And so she thought, well, stage 4 is, you're basically dead. So she just thought she was on her way to being dead. And actually, she's got very stable kidney disease. She's brilliantly fit and active. She's taken control of her own health. She's probably got kidney problems because she has used non-steroidal medications, so things like ibuprofen for other conditions. But we've managed to step in. We've managed to come up with a collaborative plan with her GP to monitor that. And she understands now what that means for her. She's not scared or panicking anymore because she knows if she keeps it in that level, she'll never need dialysis and she'll never, come to harm from the kidney problem. But actually, it's just people understanding what it means for them. And I will say that I think GPs don't always know how to explain risk. I think they're worried sometimes about getting it wrong or saying the wrong thing. And so sometimes you end up with slightly odd statements, either, oh, don't worry about it, it'll be fine, it's just one of those natural parts of aging. Or you get the opposite of, don't worry, it'll be fine, and when you need dialysis, we'll refer you to a specialist. And neither of those things is particularly helpful from a patient point of view. And I think some of it just reflects, when I'm not dealing with something that's medicine, I often feel really out of my depth in general practice because I don't feel comfortable in the way that I do. I could talk to someone about what might happen to their kidneys all day, but if you ask me about what's going to happen to their MS, I'd suddenly feel like a fish out of water in that setting. So I think, it's trying to have sensible discussions with people. I think talking to other patients, I think groups like Kidney Care UK obviously advocating for people to be signposted to them for support because they do understand the journey and they do understand the symptoms and they do understand what people are going through. But I think we just need greater understanding across the board about what it means so we can have better conversations with people at an earlier stage. And then I think we'd not be so scared about telling people they've got CKD stage 2 because we would be saying, okay, it's almost like pre-diabetes. Pre-diabetes, we're saying to people, it's not good news, but it's, we've picked this up early. There's an opportunity. We can do something now that's not drugs and, it's not turned into diabetes yet. We can do something to turn the ship around. And we need to almost be doing that with kidney health as well, saying, okay, we've noticed this blip. This is what we're going to do. We're going to monitor it proactively. We're going to put in place these lifestyle things. We're going to use these fantastic people in primary care that can support people that are trying to go on that lifestyle journey. So I think that's really, really key. I think knowing what your numbers are and how they're changing over time. So you mentioned your kidney function was getting worse. And I really like it when patients come and say to me, do you know what? I've been having a look at the graphs in my app and I've noticed this is drifting. Why is that? Because that's something you will probably spot or you might spot before someone else joins the dots. And the other thing that is daft in the system is that if you have a blood test done in the hospital, it's not automatically available to your GP. So they might not be able to join the dots, whereas often the NHS app is wedded to the GP results. So the hospital results don't always show up there either. But some of the other app systems, so our hospital has one, there's things like Patients Know Best, that actually pulls all of the blood tests in one place. So often your GP might just genuinely not be able to see some of the bloods that you've had, and they might genuinely not know that you're having that. So they will hopefully thank you if you tell them. I was having a chat actually yesterday with a GP colleague in our surgery, and she is actively going into hospital records to download the records of people to make sure that everybody that we've got that has a CKD blood test, even if it was done in the hospital, that we have got that on our record and it's documented and we know about it and it's coded so the patient can see and we can see and we're doing the right thing. Why the system's like that? It's to try and avoid all the hospital inpatient bloods and consultant bloods going through the primary care system, because every blood test that comes into primary care has to be individually looked at and then given these sort of labels that you'll have seen on the NHS app that say sort of normal, expected, satisfactory, whatever. But actually it doesn't make sense for something like chronic kidney disease, where actually it's so important to know what direction are the bloods going in, not just what's the number on a particular day.
I really think that's important because when people see me, they automatically associate me with kidneys and start a conversation about kidneys. And when I ask them, do you know what your EGFR is? They're like, no. But when I had a test, they said it's fine. And the problem with the test is, as you know, fine is all the way down to the point where it's not fine anymore. And if you don't know the actual number, you don't know the trend, you don't know if it's declining, you don't know how rapidly it's declining. You don't know any of those nuances. So I think it's really important. And one thing I really, really encourage every patient to advocate for is never accept it's fine, it's okay, or any of the sort. Know your actual number. If you don't know the number, you don't know the trend, you don't really know how you stand.
Yeah, I absolutely agree with that. And even blood pressure is another one. And you'll say, what was your blood pressure? And a patient will say, I had it done and it was fine. I'm like, but I need the numbers, because actually what's fine for a patient with chronic kidney disease and what's fine for other people is not the same. And so you really need to know what is the number and what's normal for me. And that information is obviously out there for people to access, so you can sense check what you're being told, because there is this kind of binary thing now that chronic kidney disease starts at the GFR being below 60, and we know that's not the case. So we need to try and bust that myth. And actually sort of, like I said earlier, reassuring people that actually from a patient point of view, it's much easier to be told this has dropped a bit, but we've got an opportunity, there's something we can do, we're going to keep an eye on it. That, I think is more reassuring than, oh, we've been watching it fall for 20 years and now it's hit this level and we've decided we're going to tell you now, which is, I think, what the current system almost encourages. And actually, I've got patients that, they have a GFR one day and it's 62, and the next day they've had it done somewhere else and it's 58. And they're like, do I have chronic kidney disease or not? I mean, that's becoming a bit daft, isn't it? Where we're saying that a variability from day to day means you have or haven't got a condition. We should be looking at the person as a whole rather than these sort of fixed cut-offs. And that's where knowing your numbers, as you say, and the sort of change in what's happening with those numbers is just so important.
So in summary, today we've looked at the subject of beyond the GP, making primary care work for kidney health. We've looked at definitions, starting at what is primary care, navigating the primary care system, the misconceptions around CKD in primary care, knowing who should cover what, whether that's primary care or secondary care, and encouraging patients, please do advocate for yourself. But this is just part one. We're actually going to do a part two where we're going to explore this subject further. And in the meantime, I would encourage the listeners to check out episodes 3, 4, and 5, which is talking about, it's defining what kidney disease is, about the stages, going more in depth into that, and also episodes 15 and 16, which is how to understand your renal blood test results. So we go more in depth about what creatinine is. We go more in depth about albumin creatinine ratio, or ACR. So do check out those episodes to make everything that we've covered today even more clear, and also so that you know what to look for in terms of advocating for yourself. Those episodes really are helpful. Those episodes are with our beloved Auntie Pat. So do check out those episodes. So in conclusion, Dr. Kristin, I'm going to leave the final word with you. And so what is your final word of encouragement for the listeners?
I'd say don't be afraid to ask questions. I think a lot of things have changed and the system needs to keep pace with that. But I think the key thing really to take away from today is knowing what your numbers are and asking to have it explained what that means to you if you're worried or concerned. I think GPs genuinely don't like people to be worried or concerned. So asking them about that, but recognizing that if you're an experienced patient, probably, you will know more about kidney disease than a GP will. So, and it's just really remembering that. But I think most times we just need to work together. I think primary care, community care, secondary care, and patients, we all need to work together to make sure that everybody understands what needs to be done and that that's individualized to people so they know what targets they're aiming for, they know what's normal, they know what they can do for themselves. And we need to start having those conversations earlier so that instead of waiting until things have got to a stage which feels quite advanced, that actually patients are given information early and encouraged to sort of keep an eye on their own results and things like that. So yeah, I think that would be my take home.
Thank you so much for joining me. Thank you so much for the information that you've shared. I know this will help so many patients understand about primary care, and I look forward to part 2 where we will further explore this topic. But in the meantime, thank you very much.
Thank you.
Thank you for listening to Diary of a Kidney Warrior podcast. I truly appreciate your support. New episodes of this podcast are released every other Monday, so make sure you subscribe so you don't miss future episodes. And if you found this episode helpful, why not share it with someone who might benefit too? To stay up to date with the latest episodes, news and resources, sign up for the email mailing list and join the WhatsApp channel. All the details are in the episode description. Until next time, take care and choose to live.